go.
We appreciate everyone joining us today, and we are very excited to have Dr. Randy Stevens with us, who will present his expert knowledge on medication assistance treatment. The webinar will be recorded and added to our resources for all of our members around the state. Just a few quick housekeeping items before we begin. As I stated, we will be recording today's session, and it will be available on our YouTube channel later this week once the recording is processed. If at any point during the presentation you want to ask a question, you can either use the chat function or you can use the Q&A function. Both of these are accessible by hovering your mouse over the screen. They should pop up either at the top or bottom of your screen, depending on what view mode you are in. IRHA staff will keep an eye out for these questions and will moderate for Dr. Stevens so he doesn't have to check them as he presents. Thank you, Dr. Stevens, for joining us.
Well, thank you.
A few other housekeeping items. Continuing education credits are being offered through the Indiana State University School of Nursing, College of Health and Human Services Continuing Nursing Education Program. Once you log into the webinar, you will be asked to sign a verification of attendance form, and an evaluation form must also be completed. Dr. Stevens?
Well, thank you. And let me start out by saying that I have no conflict of interest, that I need to report. So I'll say that as a beginning. And you can go to the next slides then. Gotcha. And before I go into this, anyone giving a talk can't start it without saying something about COVID-19 right now. And so I'm going to say this, kind of the numbers that were reported this morning on national TV is that we've gone over 58,000 deaths basically since March 1st. From COVID-19, and that has surpassed the number of people who were killed in the Vietnam War. As a Vietnam veteran, that's sensitive to me, but wow, that was a decade in the making, and this one has happened in less than 2 months. I was just asked this week, boy, the numbers seem to be going down in a lot of places. Boy, are we over this? Is it going away? And the statement that I made locally is this, quite frankly, we're at the foothills of the mountain. This is going to be going on for the next 16 to 18 months, short of a vaccine that comes out or a very effective treatment. So life is going to be changed for all of us, but we have to utilize things that we know to do, wearing masks when you're out in public, hand washing techniques, social distancing. So don't let down your guard at this time. Listen to the scientists and the physicians involved with this, and we'll all get through this. And one thing that's been impacted, quite frankly, in the field of addiction is obviously groups getting together and things like that. And I'm proud to say that different organizations have stepped up, and 12-step programs are being done on Zoom and things like that, and keep giving people support. Counseling sessions are taking place, and I've utilized telemedicine to continue people on medication-assisted treatment. So things are happening, and so we wanted to go through today why I personally think that, especially in primary care physicians' offices and psychiatrists' offices, why you should be utilizing medication-assisted treatment for opiate use disorder. So I'll ask you to go to the next slide. Let's see here. So we're going to actually go over different medications and things that the FDA have approved for use with diagnosis of opiate use disorder. So next slide. The one that should jump out for everyone, because it's been around for over 50 years, and that is methadone. Methadone clinics. And they have been shown to be an effective model in treating people with serious, severe opiate use disorder. They have to be approved by the DEA and state agencies. In regard to its opiate status, it's considered really a full opiate agonist. It affects all receptors in the brain that are affected by opiates in general. Indiana, for many, many years, had not approved any new methadone clinics in the state until 3 or 4 years ago. The state legislature, in the midst of the opiate crisis, authorized 6 new state or clinics in the state, and the first one to open up took place in Terre Haute, Indiana. We had never had one before. It's part of the mental health center, and since that time, I believe another 13 have been authorized, with the goal that hopefully that within an hour's drive of everyone within the state, there would be a clinic that a person could go to get methadone and be monitored closely. So that's one of the medications. Next slide, please. Buprenorphine / Naloxone, actually it's a combination medicine, commonly known as Suboxone, and it can be given by a physician, and within the last couple of years has been authorized for nurse practitioners and PAs who have a special license approved by the DEA. Again, it falls into the category of being a partial agonist. It doesn't affect every receptor in the brain for opiates, but it's primarily attached to one called the mu receptor. Now, this is a medicine, interestingly, in the year 2002, for the first time ever, the DEA said, wow, if you were willing to go through a course and get certified to be able to prescribe this, you could do this in your own office. And literally in 2003, I went and took the course and became certified to be able to prescribe the medicine. And since that time, has prescribed it to hundreds of patients. And from the very beginning, I kind of tried to emphasize that, boy, I thought this was a thing primary care physicians should really jump on. Hey, this should be something offered in your offices. And very reluctantly, physicians were willing to do that. And I say it kind of dramatically like this, that about 1 million physicians in the United States have DEA license and so can prescribe any scheduled medicine and any opiate medication that they deem hopefully appropriate and medically necessary. But up until just a couple of years ago, that there were only 32,000 physicians in the entire country that had gotten a special DEA license to prescribe this medicine to help people get off of opiates. And that was partially the reason that Congress expanded things to allow NPs and PAs, especially in rural areas, to be able to offer this to as a treatment, very effective treatment right out of your office. So that is definitely available, and some breaking news on this, and literally just this week this happened, and that is the DEA has allowed that medical students throughout the United States can take the course for being able to prescribe this. So when they graduate from medical school and then get into a residency, that when they apply for their own DEA number, that they can apply for this license too. And I think this is a game changer. What that will force medical schools to do, including IU, hey, you're going to have a robust education to medical students on opiate use disorders and other addictions. And you're going to have a tool that you can help people as soon as you come out of medical school. So that's has been sent to all IU medical students now. And again, another 3 or 4 years from now, I hope all 1,000 medical students at IU, have been taking this course and be able to offer this as a treatment when they get out. Okay, next slide. Naltrexone, Vitriol can be given at your clinic too. It doesn't require any type of special license. It is a complete opiate antagonist. At the community health clinic that I'm associated with, this is a treatment that has been utilized for now the last several years. And the way that they've kind of done it at a primary care physician is that we have alcohol and drug counselors, we have social workers, we have psychologists, and that psychiatrists and psychiatric nurse practitioners are been able to prescribe Suboxone to those people, and then once in a pretty strong recovery have been offered to change over to this medicine. And that has turned out to be pretty effective in people who have gone through the program. And so it's definitely out there. I see a lot of criminal in places that they, things like jails and things like that, have been able to offer that as a treatment too, before a person ever gets out of a particular incarceration setting, and also have some treatment before they ever leave jails. Okay, next slide. Okay, this is the one that we've heard about, and that is Narcan and Naloxone is an opiate antagonist used to reduce overdoses, and that fortunately Indiana was ahead of the game a couple years ago when they authorized that literally anyone could come into a pharmacist and request this medications, no questions asked why they were getting it. And most recently that Indiana put into place for the prescribing of Suboxone, that you have to also co-prescribe this medicine to anyone with an opiate use disorder. So that's kind of a new rule that took place since July of last year, and that has worked out pretty good, and because it gives you an opportunity to talk to people a little bit further about their opiate use. Next slide. This is medicine that's kind of interesting that got approved in 2018, and you see it right there, central alpha-2 agonist that binds the receptor on adrenergic neurons. Now, another medicine that is the very same type of medicine that we've used really for 30 years for hypertension is Catapres. And before Suboxone days, that was a common type of treatment that you gave people who were going through withdrawal. And Catapres has never had the approval to do it. This medicine is. I'd always say before the Suboxone days that you could use that, and maybe it might wipe out 20 or 30% of the symptoms of withdrawal. So not very effective like that. So I don't know if too many people are prescribing this, but I tell physicians to call me if they don't have the license. This is something that they can offer to patients. So next slide. Okay, the FDA has approved a couple of kind of interesting electronic stimulators to help people withdraw. So here is one, and go to the next slide. And so there's a couple that are out there in the market, and again, I have seen it utilized a little bit. But the FDA gave their approval for this. This one was kind of interesting in that it kind of works as a stimulator on the ear. Now, I'm a believer in acupuncture for different types of things. And one thing that I like acupuncture for is auricular acupuncture of the ear. And I saw that utilized, quite frankly, in Lincoln Hospital in the Bronx, New York. One of the hospitals right in the epicenter of the coronavirus situation, but a clinic where people could come off the streets, walk in, and get auricular acupuncture. And I saw up to 100 people at a time in a big conference room getting that type of treatment. And I kind of became a believer in it way back then. And in our community, we have one provider who does that, and that is my wife. And she has quite a following of people who come in trying to get off nicotine and other type of drugs for that. So always keep your eyes and ears open for kind of unique type of treatments, and this is one. Next slide. Yeah, that's more on the auricular neurostimulator. So go ahead to the next slide. Wow. We all know the statistics. We all know the numbers. This was probably at the end of 2017, saying about 50,000 Americans died. Well, that turned out to be really the next year up to about 70,000. And then the year after that, we think we've seen a dip down to about 67,000 people dying from overdose of opiates. So maybe we've turned a little bit of a corner, but only time will tell, but point being, we'd seen that increase taking place over really, 15 years. So next slide. So as a result of that, all of a sudden, life expectancy in the United States, based on, boy, if you're born today, what is your life expectancy over the course of your lifetime? For the first time ever, 2 years in a row, life expectancy in the United States went down. Wow, I have no idea what is going to happen now, again, with COVID-19 as being part of that number too. But point being, definitely has been tied 2 downward years in a row to drug overdoses, and unfortunately suicide rates seem to be increasing. Next slide. I never miss an opportunity to say this, that wow, as we have talked a lot about opioids and opiate overdoses, methamphetamine is back. And I really kind of say it never really left. Maybe it got diminished a little bit. But if you talk to ER doctors around the state, around the country, especially in the Midwest, and you ask them what they are seeing, the word methamphetamine always comes up. So it's back. Okay, next slide. As a matter of fact, this was an article in a medical journal that was kind of fascinating to me, and there's the title of it. Good intentions gone bad, and industry gone rogue, and watchdogs gone to sleep. Whoa. The state of Indiana, as most people listening to this would know, that we put in place in the year 2013 rules for prescribing opiate medication to people who are going to use them chronically. And I was part of that discussion through the Indiana State Medical Association. And I think we did a pretty good job in making clear, wow, if you're going to have a person chronically on these medicines for months or years or the rest of their life, here are the things you need to do. And some of them are very basic, very simple, and that is, hey, make sure you have a diagnosis, that this is an appropriate medication that is to be used. And wow, because of the highly addictive nature of the medicines, have people sign contracts, let them know that you're going to do some urine drug screens to make sure that the medicines you're prescribing to them is actually they're utilizing, and there's no other illicit drugs that they're using. So all those things started taking place in Indiana 2013, and most providers follow that to the T pretty well. as I think everybody knows too, now we have some acute rules, and that is, wow, no longer can you go to an emergency room and that you sprained your ankle very badly. I'll say it's swollen 3 times its normal size and you can't walk on it, you're going on crutches. But no longer will anybody prescribe you a month-long a prescription of opiate medication. You know, actually an acute first prescription is limited to 7 days at the most, and a lot of ER doctors will limit it even more than that and say, please follow up with your appropriate doctor who's going to see you after the ER visit. So we put some pretty good things in place that I think that has some good results so far. Go to the next slide. In that same article that you just saw the title of, this was a fascinating picture of the United States, and this is really the influence of major Mexican drug cartels on distribution of opiates throughout the United States. And if you see some really red areas, see that right in central United States, including the state of Indiana and Ohio, you see a lot of distribution sites take place in that. Now, I always interject that down at the bottom tip of Texas, down there, you can't read it, but that says McAllen, Texas, that my son was a Border Patrol agent down in McAllen, Texas for about 7 years, and heavy confiscating of illicit drugs coming across the border down in that area. But also that is the start of I-69. When I used to go visiting there, that there was the signs, future home of I-69. So I always knew a few years later, my gosh, that's a straight pipeline up to Indiana, coming right out of McAllen, Texas. And so a tough situation. Now he's gone on, he's up at the Sault Ste. Marie's on the Canadian border now, and I promise you things are a little bit different for him up there. Next slide. I always take time to interject this, and that is, this is a picture taken in the Central Highlands of Vietnam when I was there in 1971. And the reason I put that in there, I was a medic, and one thing that really was not trained on, educated about until I got there was, wow, a lot of American GIs were now using hashish and definitely marijuana, but also heroin, pure heroin, in Asia. And that over the course, of a year there, unfortunately saw too many people die of overdoses from heroin, and so much so that they instituted in the Army for the first time ever urine drug testing of soldiers. And that took place in Vietnam, and I will say Germany and things like that. And one of my responsibilities as a medic was urine drug testing GIs way back then. So, well, we all know the story, but that's where I first saw heroin being used. And once I came back to the States and eventually back to my hometown of Terre Haute, Indiana, well, I never saw heroin again, ever, until about the last 5 years. And now, as everybody knows the rest of the story, it's pretty rampant around the country and here too. Next slide. Now, matter of fact, I threw this out, and this is from New England Journal of Medicine in the year 2006. And way back in the early 2000s, all the talks I were ever asked to give was always about methamphetamine. And all of a sudden, first time ever in my career, I sent out a letter to all physicians around here saying, hey, the drugs of choice, especially for teenagers, is changing, and it's actually turned out to be prescription drugs, prescription opiate medications. So just a word of advice to physicians, please monitor your prescriptions closely, because as has been shown by subsequent research, that most people who began using prescription drugs got them from their friends or from other medicine cabinets and things like that. So please be careful of your prescribing. So that was back in 2006 that I was kind of starting to be aware of this. Next slide. So you heard me say at the beginning of this that, boy, in 2002, I thought this is the realm of something that family doctors, primary care physicians should be offering to people. And sure enough, a couple of years ago, the Journal of Family Practice has that as its cover, buprenorphine to treat opiate use disorders. So, wow, that was perfect for me to see. And I will say, as a result of this type of thing, that I've seen changes where all of a sudden in residencies that they've offered residents to take the course and get the license to prescribe. And we've done that here locally. And literally every week I have a resident with me who's talking to me about a patient that they're prescribing buprenorphine for, or seeing patients of mine with me so they get a feel for how this is done. And I always emphasize to them, hey, this is very rewarding. You will see people who were in the midst of a horrible addiction that you have helped them, get past that and have successful careers of finish in college and in the workforce. And so this can be a life changer, for people. So again, Journal of Family Practice had that. And so next slide. So a practical guide, and in essence, what this is saying is that using this medication is definitely superior to just offering, and the only thing you're offering is an abstinence program, 12-step programs and counseling. That if you compare them, that no two ways about it, the medication assistant treatment is very necessary. So much so that a lot of nationally known programs who were very resistant to prescribing medications have since come to realize that no, this is a very effective and appropriate tool to be able to utilize too. So, and a matter of fact, my personal journey through this was that when I first started prescribing it, since my whole career as both a family doctor and an addiction medicine doctor, was that, wow, total abstinence, boy, you're using cocaine, you're using methamphetamine, you're using alcohol, got to stay away from all of those, 100%, no two ways about it. And same type of philosophy for me was with opiates. Nope, you got to stay away from everything and let's do the same program. But when I started prescribing this, I initially said, I'm never going to prescribe this as a maintenance medication. I know they say to do that, but no, I'm going to detox people. We'll keep them on the medicine for a month or two, get them into program, get them all better and on the road to recovery. And after a year of doing that, for me personally, that all of a sudden at the end of that year, I realized nobody was completely drug-free after 12 months. They had all relapsed. They all went back to their old ways. And so I kind of transformed into using this as a maintenance medication, which is what it's recommended for. And that has made all the world of difference in the patients I see. So next slide. This is an article that basically says, well, how prepared do physicians feel when they finish all their training program that they are prepared and ready to treat an opiate use disorder patient? And right there in the middle, they says only about 10% of people felt that they were prepared. So that kind of spoke volumes to me that we had to educate both medical students and residents better on this. Next slide. The Surgeon General, put out the word, a nice, well thought out document, Facing Addiction in America. And again, in the middle of this, one of the things that he emphasized was, hey, you should become qualified to prescribe buprenorphine for treatment of opiate use disorders. That was his main theme, through this. So yeah, everybody's saying the same thing now. Next slide. You saw these numbers already, and that is but number of deaths. And again, same type of message from the CDC saying, wow, we need to have more people expanding there at the end, expanding the use of medication-assisted treatment for addiction. Next slide. If you dig into this, there's actually DSM-5, Psychiatric Criteria for Opiate Use Disorders, and this fits basically for any type of addiction, alcohol, cocaine, or whatever. But wow, are you taking opiates here in larger amounts than you intended? Is there persistent desire or unsuccessful attempts to cut down? Is a great deal of your time spent in activities to obtain opiates? In talking to patients who were really in the throes of opiate addiction several years ago, one lady, I'll say classically the way that she told me, she said, you can always complain of teeth pain to a dentist. Now, this was several years ago, and you can always get something called out from some dentist, someplace, over the phone. And so she said, I had 8 dentists, different dentists that I could call at different times to get medications I needed, plus seeing my primary care physician with my complaint of intractable headaches and stuff. Well, this woman I've had on buprenorphine now probably for about 5 years at the tiniest dose of anybody I prescribe it for, and she's done great and things like that. But point being, there are criteria that people can look at and learn about to be able to figure out whether or not this person fulfills the criteria. Next slide. This was in the article, so I think it's worthwhile just to go through it a little bit. So here's a 55-year-old man who's taken oxycodone 70 milligrams a day for over a decade and is coming to get his routine prescription refilled, and that all of a sudden he's been escalating the dose over the last 6 months, and he was recently discharged from the hospital after an overdose of opiates. Wow, that is a red flag. Wow. And I'll say this, there's a top addiction psychiatrist out at Stanford in California, and Limke, something like that is her last name. And she wrote an article in the New England Journal, says, why do physicians continue to prescribe opiates to people who are abusing them and overdose on them? Whoa, that stunned me. I didn't think I really believed it. And about 6 months after reading her article, I was at a CME in California, and her name wasn't even on the list of speakers, but she had to fill in for someone. So all of a sudden she was right in front of me, talking about that. And I kind of stood up and kind of challenged her in a group of about 400 doctors. And I said, who here as a doctor ever continues to prescribe to people who are abusing the drug or have overdosed on the drug? And out of 400 doctors, not one hand went up. And I kind of used that as proof. And I said, see, none of us do that. And she says, well, I'm going to say this to all of you. That's maybe what you're saying, but that's not what the research shows us. You do this. And she went on to show all the research she had done. And she ended up convincing me at the end of the visit that, yeah, doctors were still doing that. Wow. That's why I emphasize that point. Hey, somebody overdoses on an opiate, you better be looking and reasons to get them off of it, because it's going to be a very bad outcome. So as you can see, this fella, he ends up writing out of medicine, goes to heroin. The COWS is the withdrawal scale. And so sure enough, he is withdrawing as this doctor is seeing him. Next slide. So this was in the article that in our experience that if you give a person now 2 to 4 milligrams of buprenorphine followed by an hour assessment of withdrawal, that's usually kind of the starting dose to get people through this. And that is, this has always been a little bit of the hang up for physicians, and that is where you're asked that person takes the first dose of medicine right there in your office so that you know that they're going to do okay. I will say they're easing off of that, and I a lot of times will send a person home and have them come back to see me after I've given them an initial dose. But I'll go ahead, next slide. And so after you've discussed this with the person and you drew blood for liver function, hepatitis, HIV, and I'll throw this out that, again, this is all in the rules in Indiana for prescribing buprenorphine to a patient. You have to measure and screen for that. And I'll throw out one more. If this were a female of age producing or a child producing bearing age of, we say generally 15 to 55, that you have to have also counseled them on neonatal withdrawal syndrome and things like that, and have them sign contracts just like you would for any chronic pain medicines of opiates you're given. So in this person that he ended up prescribing the person a 2 milligram dose, told him how to use it. Actually, the prescription was for 8 films. This comes in a film and tablets, and then says, hey, I want to see you back in a couple of days to see how you're doing. Comes back and the person's doing okay. He's really taken about 6 milligrams during the course of the day, but still having some cravings. So now he prescribes him an 8 milligram dose and says he's come back in 5 days. Point being, initially when you put a person on this medicine, you're watching them pretty closely for the first few weeks, and that's what they're demonstrating here. So go to the next slide. So at the next visit, he comes in, he's still craving oxycodone. So you increase it now to a 12 milligram dose. And right here, I'll say that the average dose in the United States of America turns out to be about 16 milligrams. And me personally, my average dose is probably a little bit lower than that, 12 to 8. I found to be very effective, and the vast majority of people. I have people on 2 that have done very well, and then I have a couple individuals that have gone up to 24, and that's getting pretty close to the maximum of any effectiveness. Point being, people generally do pretty good. Unfortunately, this fella all of a sudden was doing fine, and then all of a sudden he disappeared for a while, comes back, they do a urine drug screen, they find morphine, which turns out to be, a byproduct of really heroin use, and that now you're sitting there talking with him about what was happening, and he was saying he was still craving the oxycodone and all that. And this is where I emphasize this pretty strongly. So you did not all of a sudden look at this person and say, hey, you failed this miserably, I'm not prescribing it again, we're over and done, you find another doctor. Instead, say, wow, you know what I think we probably need to do? We need to boost up your dosing of this. And again, to the point that you're not craving, you're not dreaming about drugs, which I promise happens to people. And once a person tells me they're not doing that, I know they're at a pretty effective dose. So, and that's what they did for this fella. Okay, next slide. So kind of practice recommendations from the article was, well, should you just use signs of intoxications, withdrawal, doing urine drug screens, things like that? Is that a good way just to pick up people who are abusing drugs? Well, that gives a nice rating of a C. That, okay, something you can do, but not the best. Can you offer and institute medication-assisted treatment when appropriate to reduce the risk and overall mortality of patients? Hey, that's a clear A rating for that. Yeah, thing to do. And should you identify and treat any other psychiatric problems in people with opiate use disorders? Yeah, I promise you that they're there, both anxiety disorders, depression, bipolar, you name it, you'll find it if you look for it. So yeah, should you look for those things too? Yeah. And so that's an A rating for things to do. Next slide. So bottom line, hopefully for all of us, is this, and that is treat addiction as you would any other chronic disease. Anticipate relapse. Wow, if a person never relapses, we're happy as we'll ever be for someone. But if they do, wow, let's go the step further with them. How do we prevent that from happening again? Engage in support systems. Work with the patient to obtain a higher level of care if they are having struggles. So I think that was the last slide. Is that correct? Yeah. And we'll open for any questions that may have been stirred from any of that.
I will turn to our assistant to ask those questions of Dr. Stevens. Did we have any?
We have one in the Q&A section.
Okay.
Dr. Stevens, how does a doctor determine when a patient comes off of the mat? Are you saying they're on it for a lifetime?
Okay. And that is, in my personal experience, and this is what they would say, that it can be a lifelong medication, just as antihypertensives are, diabetic medicines are. Having said that, I've had very successful people who have been on the medicine for, I will say, a few years. Everything is going great in their life, and that they elected they would like to come off the medicine, and that is a tapering of dose. And as long as I say you're not craving, you're not dreaming about drugs again, let's continue on this. So I very successfully had people come off the medicine, but also have people who are on it. And again, when I think of people who for 6 or 7 years were living the life of injecting heroin, and getting heroin from any place that they could and things like that. Ooh, those are pretty high risk people. And I've had people who, again, very successful in their career now. And when we have discussed, the possibility of going off medication, that they've looked me in the eye and said, I remember what my life was like before this, and I'm not willing to risk that. And one person who said that to me real clearly, I got introduced to him at the Vigo County Jail after about his third trip there of selling drugs and all that. And I promise you, this individual is a highly successful national salesperson for a company, and has 3 teenage daughters, 2 of them in college right now. And he's had the most open discussion with them and his wife. And no, this is a lifelong medicine for me. Don't need to discuss with me ever coming off of it. So I see both.
Dr. Stevens, we've had as many as 45 participants during your webinar, so obviously you have a following, and there will be more who will be tuning in on our YouTube channel and on our learning platform. So, I appreciate your expertise on the MAT. I do have a couple questions. So the graph that ended in 2016 and would continue on to 2020, does the male gender continue to outperform the female gender when it comes to opiate use? And then my second question is...
Yes, okay.
Go ahead and answer the first one. The first
Okay.
one was yes?
Yeah, the first one's going to be easy. Yes, still. Yes.
Okay, my second question is, I appreciate your local coverage of the COVID-19 and with our press, so thank you for that. As a physician, have you seen an increase in opiate use and other types of drug and substance abuse during this time?
Yeah, and that's up for a little bit of debate. The risk is definitely there. Okay, and some people have dropped out of programs. Again, is it because of not easy access to come in and things like that? And does that mean that they're not doing very well? I have my concerns, and nationally, the answer has come back yes, that they do think that nationally they're seeing that happen. But you heard me say early on that while some of these 12-step programs have gone to Zoom meetings and things like that, so people still have some access to some support, but the people who dropped out of things, wow, I'm concerned about them, yes.
Okay, I saw another question come through. What are possible negative effects of this treatment? This comes from Patty McFeely, and I'm not sure which treatment she's talking about.
Probably the, just the medication-assisted treatment.
MAT.
Yeah. I'll say this, and that is a couple of years ago, there was really a strong debate among physicians, should methadone clinics still be in existence? Okay. And the question that was raised was, and which is a true comment, and that is, boy, we've seen skyrocketing number of deaths from methadone. And so, wow, is that something that's harming people, methadone clinics versus not? Well, here's the correct answer to that, because it's been studied and researched, that as far as overdose of methadone from a methadone clinic patient, those numbers are very, very, very low, and they're monitored pretty closely, and they haven't seen a bump in that for decades. Okay. The methadone deaths that were increasing was, unfortunately, I will say, primary care doctors who were treating pain with methadone. Whoa. And one of the reasons was methadone was pretty cheap as a opiate medication. It's been around forever generically, but it's also a very tricky medicine to prescribe. Its half-life is extremely long, and so you don't double the dose, basically for a week, even if a person is still having pain, because you don't know what dose it's going to take. And now people were inadvertently overdosing from some of the prescribing habits of doctors. And so the overdose was nothing to do with the methadone clinics. In regard to buprenorphine, now if I were presenting to a law enforcement group, they would say, "Oh, doc, this drug is on the street. It's being used on the street." Well, and actually it's been snuck into jails because of the film, that all of a sudden it might be put in a letter or put in a book somewhere. And well, okay, those are real issues, true issues. But I said two ways around it. I said there is a tablet form. So if you have any concerns about that, there's actually even an injection form, okay, that you can use once a month injection. But that all the studies that have really looked at the diversion of buprenorphine, so Suboxone, and that occurs in about 7% of the prescriptions, that the vast majority of them, people are diverting that to try to block somebody's withdrawal from opiates. So they are actually using it as a medication to block withdrawal, not to get high, because most people, who have been addicted to opiates do not describe a real high feeling with buprenorphine at all, which is a great thing. they don't get high, and that and it was used for withdrawal. And the argument was, hey, if we had more prescribers of this would probably be less of a diversion. And so I'm kind of the believer in that, and that is if people are being prescribed it appropriately, there would be less need for it to be diverted to places. Yeah.
So did you see the question about the buprenorphine? Do you prescribe buprenorphine for any diagnoses other than OUD?
Okay, and that is okay. Yeah, I do have a couple of patients and who have benefited from use of the buprenorphine as a chronic pain medicine. When it was first, brought out into the public, I was a resident in the 1980s, and it came up under an injection form called Buprenex, and I was working in ERs, and boy, it was a pretty effective medication to use. So I've always had that little history of saying that. And so in a couple of really tough patients, believe it or not, really tough patients who, had a tendency to use too much pain medicine, not because of really, an opiate use disorder, in my opinion, but because of that. And one fellow comes to mind, a fellow that had 2 morphine pumps put in his spine, and they both eventually malfunctioned, and so he has these 2 pumps in his spine, and wow, what could he use? Believe it or not, for 5 years, I prescribed him, how about this dose, 4 milligrams of buprenorphine a day. That's a small dose, and he's done fine. He's done fine. Wow. So yeah, and a matter of fact, in New England Journal of Medicine, in some of their articles, they're a lot of times buried in a paragraph somewhere, says, boy, this might be the most appropriate medicine to use for moderate pain in somebody that you were going to use. Because I will say the overdose risk, and I should have said this, overdose risk of buprenorphine is almost next to nothing, because there's a ceiling effect of it. And I always say it this way, and that is, ask your ER doctors how many overdose deaths of buprenorphine, Suboxone, have you seen in your career? And every ER doctor I've ever asked that to personally has said 0. They've never seen it. Now, theoretically, it can happen, and it does happen, but it's usually a combination of alcohol and other drugs and things like that. So there's some merit in using it for pain.
Dr. Stevens, we have another question.
Okay.
What has your experience been with injectable naltrexone for treatment of OUD and AUD?
Okay, and that is at the clinic I'm at Valley Professional, they use that pretty much routinely, and they have pretty good success with that. Now, these are people who have gone through a program for several months to a year and then transferred over to the injectable form. And so, wow. So I think that is very good. I told them I'd love to see them publish their data, because if they're equally as effective as buprenorphine, we need to get that word out. And if it's not, then we know that's a pretty select group of individuals that would benefit from that. So yeah, so the word's still out on it, but there's no 2 ways about it. That early part of recovery, when a person's first coming off heroin, first coming off things, boy, you've got to get them through that withdrawal. There's no 2 ways about that, and buprenorphine is the way to do that, in my opinion. Okay.
Very good. I think that is all of our questions for today. And we appreciate everyone joining us. Dr. Stevens, we truly appreciate your participation and your expert advice and presentation on MAT. And again, this session has been recorded, and it will be available on the Indiana Rural Health Association's YouTube channel later this week. once the recording is processed. So thank you all and have a great day.
Thank you, Tina. Thanks for the opportunity to speak to the group. It's a great organization you have. I will say that. I'll brag about you.